Good morning, everybody, and welcome from the Stoke Mandeville Plastic Surgery Unit in the UK. My name is James Chan. So the topic of the day today is vascularized composite allotransplantation. And there's no better person than Professor Luke Lin to come and share the experience with us. And Professor Luke Lin is from the Cheng-Hung Memorial Hospital in Taiwan. He was one of my teachers and a mentor whilst I was a fellow out there. He's Chief of Division of the Trauma and Emergency Surgery Service, the Plastic Surgery and, Plastic and Reconstructive Surgery Department, and also Director of the Clinical Trial for Hand and Upper Extremity Allotransplantation at Cheng-Hung. Luke is right in the prime of his career and has already accomplished more than what any one of us could dream of in a lifetime. So many congratulations, Luke. Luke was a research fellow in the transplantation unit in Pittsburgh and Johns Hopkins in the US. And he has now led his team at Cheng-Hung to accomplish the first bilateral forearm transplantation and also the first arm transplantation in Taiwan. So it's my immense privilege to welcome him here today to share his experiences with us. Just before we start, just wanted to remind people that we would welcome any comments and questions they have. And please, if you do have any of these, as the talk goes on, please use the Q&A function at the bottom right of your screens, and we'll try and get to them at the end of the Q&A session. So Luke, thank you very much. Lovely to see you. Looking forward to your talk.
Okay. Thank you, James, for your kind introduction. I am very happy to have this opportunity to share our experience in vascularized composite allotransplantation at Cheng-Hung. So in the first speech, I will have my screen first. Is that okay?
No, not yet.
Not yet. It's okay now?
Perfect.
Okay.
Thank you.
So, this evening, actually in Taipei, I would like to share with you about the vascularized composite allotransplantation at Cheng-Hung from bench to clinic. Because for us, bench study is quite important. It's the fundamental of the clinical VCA. Based on the clinical research, we can feedback to the bench study. So in this talk, I will briefly introduce what we do at Cheng-Hung. So in 2014, microsurgery was elected as the most important plastic surgery innovation by two privileged Society of Plastic Surgery. So at Cheng-Hung, you can see until the end of last year, we have more than 22,000 cases with major microsurgery, including free flap, replantation, brachial plexus, hepatic artery, anastomosis, and LVA. So what is the microsurgical reconstructive layer? If the amputated part can be replantation, we will do the replantation attempt first. Like this case, it's very difficult to replant a degloved hand, but if we can reattach the degloved envelope back to the hand, the reward will be wonderful. But if the amputated part cannot be restored by replantation, we may try autologous transplantation. So in the right side, you can see until now there are many flaps developed for the autologous transplantation. Like another case also showed the degloved envelope was gone, but we cannot find the degloved envelope. So we will have the autologous tissue coverage first. Then we use the growing flap to cover the defect, then separate each digit, then do the simultaneous 3-toe transplantation, then you can see that finally the patient can achieve very good outcome and can have the sum up. But if we encounter extensive face defect or the amputation proximal to the wrist or elbow, we may not use the autologous transplantation to achieve optimal function. We may consider vascularized composite allotransplantation, which just follow Sir Harold Gillis replace like with like principle. So what is the vascularized composite allotransplantation? It means transplant a grafted composite of variety of heterogeneous antigenic tissues across a genetic mismatch, just like a hand transplantation with the bone, muscle, nerve, and vessel. So compared to the homogeneous solid organ transplantation, it have a multi-barrier and complexity. So what is the role of the plastic surgery in vascularized composite allotransplantation? I think the successful vascularized composite allotransplantation need to combine the technique of plastic surgery and also with the immunology from the transplantation side. Then of course, we need to have the suitable donor and recipient match. Then finally, we may have a successful vascularized composite allotransplantation. John Murray is the Nobel laureate who won the Nobel Prize in 1990. In his biography, he mentioned, "My rewarding career has combined two major professional disciplines, plastic and reconstructive surgery and transplantation biology." And he also quoted Mr. Stuart Brand's word, "Once a new technique rolls over you, if you are not part of the steamroller, you are part of the road." In his old age, I think the vascularized composite allotransplantation is the new technology for him. And this is a timeline of the vascularized composite allotransplantation. I will describe the detail later, but you can see the beginning of the vascularized composite allotransplantation came back to 348 AD. In that time, we can say it's the legend of the black leg. The Saint Cosmos and Damian, he transplanted the Ethiopian black man to a white guy, but of course, without microsurgical technique and modern immunosuppression drug, it failed. But in 1908, Dr. Alice Correa first proposed a triangular method for vascular anastomosis, and he opened a new era for transplantation. And Dr. John Murray first performed a kidney transplantation on identical twin in 1954, and he won the Nobel Prize in 1990. But after that, the first trial for the hand transplantation happened on 1963, performed in Ecuador. But at that time, because the lack of the modern immunosuppression drug, the patient received the amputation 3 weeks after transplantation. After that, because this is a tragedy for the transplantation society. So after that, even we have the modern immunosuppression like tacrolimus and cyclosporin in the market, and other solid organ transplantation like liver and kidney actually developed very well. But because this tragedy happened in 1963, it postponed the modern VCA until 19 98. So because of why I use this diet, we usually use immunosuppression for kidney transplantation as a immunosuppression for vascularized composite allotransplantation, like hand and face transplantation. So you can see after introduction of cyclosporine, we can find the rejection rate decreased and survival rate significantly improved. So after that, my mentor, Dr. NDD, find the interesting things in the relative antigenicity of the allograft, because we all know the skin actually have the most antigenic tissue in the composite allotransplantation. But Dr. Lee find if we transplant the whole limb, actually we can find the less alloreactive response from the transplantation. So it gives a hint for the transplantation society. Maybe based on modern immunosuppression drug, we can try the transplantation, especially like the hand transplantation again. So in 1998, Dr. Dugna group in France performed the first hand transplantation. And 2005, the same group also performed the first human partial face transplantation. So in the same article I mentioned previously, the hand and face transplantation was elected as the most important plastic surgery innovation of the modern era. Until now, there are so many countries in the world have the clinical VCA program. And how about VCA research at Cheng-Hung? We have the VCA research since 2000, founded by Dr. Fu Qianwei. Initially, we established various VCA animal models. Then we want to find the mechanism to induce donor-specific tolerance with various combination of irradiation, immunosuppression, and cell therapy. Then we want to know the molecular mechanism. Then we want to find if there are any way to do the functional assessment after vascularized composite allotransplantation. And we also established the Center for VCA since 2011. And now we have the 4 subgroups, include a molecular mechanism, animal model, clinical study, image and functional recovery. And we also have the domestic and international collaborators. For the VCA research, until now, we have the peer review article more than 60. Then we also get the national grants year by year, increased and give us several honor. And we also publish 1 booklet from auto to allotransplantation. So what is the difference between the vascularized composite allotransplantation versus solid organ transplantation? I think there are 3 unique characteristics of vascularized composite allotransplantation. The first one is skin. Although the skin is the most antigenic, and not in the other way, it will be very easy for us to observe and can detect the rejection before other parts show rejection like the muscle and bone. And especially we can use the topical agents to treat the minor rejection. And the allograft also have the bone. So the bone actually is a unique part for us in the basic research. Now my major interest is focus on vascularized bone marrow transplantation. And not like other solid organ transplantation, we not only restore the appearance, we also need to restore the function. So the nerve regeneration is also the important in the VCA study. So currently my personal project include the 4 categories. The first one is the transplantation immunology. Today, because the majority of the audience should be plastic surgeons, so I did not mention too much in immunology. I will focus on the animal model and also some functional assessment. Then move on clinical VCA. So as you know, why we need to use the mouse model, why we just use the rat model, because the mouse model have the foreign advantage, and we can have the lots of immunologic and genetic background model, and also is very cheap, and also inbred and changing strength is very useful for the VCA study. But why it's not so popular? Because when I start to do the mouse model in VCA study, I can only find 10 articles before I study, and only 3 articles use the animal model for further research. Other 7 articles just focus on how to deal with the technical difficulty in the mouse model. Why is so difficult in the mouse model? Because I think for the high limb transplantation, the most used model in the VCA study, because the femur vessel in the mice are about 0.2 to 0.4 millimeter in diameter, and it's not so only so small, but it also very thin. You can see the right figure. There is only 1 or 2 layers inside the cuff. I will show you the cuff technique later. So this is the donor vein. So you can see the wall is quite thin. So it's very difficult for us to have the suture technique to sew the vessel. And the other thing is a short vascular pedicle. But we have our solution. We use the donor vessel, use the iliac vessel, and recipient. We try to just use not at the femur area. We move to the neck. We use the common carotid artery and external jugular vein of the neck as a recipient vessel. And as I mentioned, in this situation, it's very difficult for us to use the suture technique. But as you know, now we have the super microsurgery technique. It's still okay for us to do the suture technique. But in the mouse model, I would like to introduce you another technique, is a cuff technique. So what is the cuff technique? In Alice Carrel's Nobel lecture, he mentioned before his triangular technique, he followed Pearce and Murphy's method. So what is the Pearce method? So you can, from this slide, you can see in the early 1900s, Dr. Pearce started to use a cuff technique for vascular anastomosis. But at that time, the cuff is quite thick and will cause much turbulence after anastomosis, then cause the vessel some burst later. But for this video, you can see what is the cuff technique. I just pull through the vessel through the cuff, then avert the vascular wall, then pull a ligature over the vessel. So just need to have the one ligature at this time. I'll move faster. So after I mount the cuff on the vessel, you can see the patterns Then I pour the vessel over the cuff, the other side over the cuff, then put another ligature. So totally for the cupping technique for the vascular osmosis, we just need to have the two ligature for vascular osmosis. So you can see the vessel is patent. So why I use cuff technique instead of suture technique? Although it's still feasible for us to use the super microsurgery technique to suture this tiny vessel. But as you know, each mouse only have 2.5 milliliter blood, and just a minimal leakage from the vascular osmosis will cause the recipient morbidity and mortality. So I don't want to take this risk. And the other part, because the suture technique on the recipient side will less more time for us, and the time-consuming technique will also cause another risk for the recipient survival. So that's a reason I go for cuff technique. But the disadvantage of the cuff technique is I still wonder about the long-term effectiveness. So, but in the mouse model, we put the cuff technique for more than 4 months. It's still fine for the vascular patents. And yeah, I think the major issue, just like Dr. Pear's technique, we were caused by the turbulence with the sick cuff. So what is our solution? My colleague Robert and I just find a suitable cuff material. We use the polyimide tube because at least the polyimide tube is quite thin and is strong enough to sustain the ligature. And nowadays we just go for the cuff technique, use the polyimide tube 0.4 millimeter inside diameter. And selection of the adequate size of the polyimide tube, I think is the key for the success. Initially, I just want, because as you know, if I use a small cuff for me to sew the vessel, it will be easier for me to mount the vascular wall. So initially, I just try to have the small one, but in the first 7 operations, I only got a 4 success transplantation. So then, but after that, I go for the big one. The successful rate improved. So this is a handmade cuff. And this is a 1 millimeter scale. So it's actually it's quite small. So use this, we can have the osteomyocutaneous fiber, myocutaneous fiber, and even cutaneous fiber in the mouse model. The other advantage for us to use a cuff technique, because after 4 months, it will be very difficult for us to identify the vessel in the recipient side. But with the cuff, we can easily to identify the black one. Then, and as you know, I pour the donor vessels through the cuff. So the vascular wall inside the cuff actually is from donor. It will be easy for us to identify which part is the recipient vessel, which part is the donor one. As I mentioned, I use this mouse model. Then my major interest in the basic research is vascular bone marrow transplantation, and this paper published in Nature, you can find the niche, the bone marrow niche actually is located in the the distal metaphysis at the both end. So with the vascular bone marrow transplantation, it's not necessary to have the irradiation or cell-deleted immunosuppression drug. We just need, because when we have the transplantation, we just transplant the bone marrow cell niche to the recipient. So we can also also use this model. Then for this, I transplant, because this is a red model. We transplant the osteomyocutaneous fiber to the growing area, and you can see that in the bilateral end of the femur have the strong viability. This is a luciferase rate. So you can see the signal is quite strong at the bilateral end, and this is location of metaphysis is another evidence to demonstrate this is the bone marrow niche. So after this, we have this vascular bone marrow transplantation combine co-stimulated blockade and short-term rapamycin use and achieve the long-term survival and even the tolerance of the vascular composite allotransplantation, and published in several high-impact journals. For the second part, I would like to share is the functional assessment. In this category, I use a metastatic PET transplantation. Initially, the ordinary functional assessment for the vascular composite allotransplantation, we usually use a hiding model. And also even in the nerve regeneration study, they also use the sciatic nerve injury model. But for me, because as you know, the rodent have the forelimb. If the animal leg of one leg, but it still can work very well. Even we have the publication in transplantation, but we still know some limitation for this high limb transplantation model, because the sciatic nerve regeneration route is quite long. After the animal have the nerve repair and the nerve regeneration come to the muscle maybe become atrophy. So we abandon this high limb transplantation model and go for the metastatic PET, because you know the metastatic PET have the unique pathway. We call the barrel cortex to the whisker is the unique nerve transmission pathway. Is a one-to-one transmission. So one whisker will have the transfer the signal from the whisker to the primary somatosensory cortex, then interact with the motor cortex, then back to the whisker, then have the whisker. So this pathway actually is similar to the human's hand. So, and especially the metastatic PET model have the infraorbital nerve, which is the pure sensory nerve, and the facial nerve is a pure motor nerve. So it will be easy for us to do the study. Although in the previous, we also do the hemi-phase allotransplantation in the mice, but it's another functional study. But we follow the previous study by Kia Washington and also the Lardin's model, but we have our refinement. We do the less destructive study, animal model, and also do some longitudinal study by functional MRI, which is not performed by others. So in this animal model, I just elevate the metastatic PET fab then hook up the facial nerve, which is the motor nerve, and this is the infraorbital nerve. And we also include the artery, common carotid artery, and common jugular vein, and mount with the cuff. So it will be easy for us to do the non-sutural cuff technique for the vascular osmosis. And this is, as I mentioned, this is a somatosensory pathway from the whisker to barrel cortex. And recently, we also do some electric stimulation test for identify the nerve regeneration. And this is, as I mentioned, each whisker actually will correlated to each barrel cortex. And after transplantation, we can find the whisker will move, although the whisker is not good as the healthy one. And we also can use this model to counting the angle of whisker. So, as I mentioned, I would like to have the longitudinal study. So the functional MI is the method we choose. So like this, we have the right side with the surgery. So after 1 month, we can find a signal at the left side. And the left side is without surgery, we can always have the signal. And recently, we also find, although in the beginning, we assume it's one whisker to another specific barrel cortex, but sometimes the nerve and osmosis is not so precise. So the whisker may be correlated to and regenerated to the wrong barrel cortex. But interesting, recently we find in the rodent brain, we can find the neuroplasticity. Actually, it's very similar to the human's brain. And we still do the further study for this. And we also have some publication regarding this category. And because in the clinical hand transplantation, we can find the great vascular path. And in Louisville, they do the ultrasound biomicroscopy and can detect the intima thickness. So like in our model, we can also use the ultrasound biomicroscopy to detect the common carotid arteries intima. And because the cuff always point to the donor vessel, so we can easily to identify this is the donor one, and this part is the recipient one. So it's another advantage for us to use the cuff technique in the rodent model. Then for the drug delivery, I use the hydrogel for the study because as you know, in the solid organ transplantation, the majority of the rejection comes from the immunosuppression drug non-adherence. So if we can have the long-term immunosuppression drug maybe just come to my clinic once per month, then I just give the patient one injection. They will be good enough for another month. Otherwise, in the current scenario, the patient need to have the drug every 24 hours per day. So in this project, we use a thermosensitive hydrogel to bring the tacrolimus into the animal. Then we have the skin transplantation model, hyaline transplantation model, and also the mestacial peg transplantation. Then we find only with one shot, we can prolong the skin graft, high limb and menstrual pain for more than 2 months survival. So for the final part, I would like to go to the clinical VCA, because for me, why I need to do the basic research before the clinical VCA, I think from the knowledge I gain from the basic research, it will give me more confidence to deal with some trouble and also the rejection and even some the complication after vascular composite allotransplantation. And as James mentioned, until now we have the 2 hand transplantation. I will describe later. But how about the hand surgeon attitude to the hand allotransplantation? In the 2009, there are only 24% actually go for the hand transplantation. But 5 years later, there are more than 50% go for the bilateral hand transplantation. Because I think just because the widespread of the knowledge and the immune suppression drug can reduce the rejection and also the cause acceptable side effect. And we also do the study in Taiwan. Then we can find for the bilateral hand transplantation, the more than 90 hand surgeons go for the bilateral hand transplantation, and more than 60% patients also go for the bilateral. Other category actually is not more than 50%. And you can see from the worldwide database, from the IRHCTT, you can see initially the society have the unilateral transplantation, but after that, the majority actually go for the bilateral hand transplantation. So until now, this is the slide from Dr. Vijay, my good friend. Until last year, we have the 50 unilateral hand transplantation worldwide and 55 bilateral hand transplantation worldwide. So now at Cheng-Hung, the indication for the hand transplantation, we choose the 2 candidates. The first one is bilateral hand transplantation. The second one is about elbow transplantation. Because for the why we choose the bilateral hand transplantation, as I mentioned, is we need to balance the benefit and the side effect. And I think the bilateral hand transplantation can much improve the quality of life of the patient. And for the unilateral one, maybe we can use a 3D printed spring, and we can also use a myoelectric prosthesis. And one of my patients, you can see, use a bionic hand can have very good shoe tie. And why we choose the unilateral about elbow transplantation? Because currently there is not very useful prosthesis in this kind of patient. The patient only have this kind of prosthesis to my clinic, then did not use it in the daily life. And from the literature, you can see although the function still poor than the below elbow one, but the majority of the improvement actually is still very encouraging. But there will be no intrinsic recovery, and also there's a extrinsic motor recovery. So as James mentioned, I spent 2 years in United States. So in 2009, I had the chance to went to Pittsburgh. And before that, Dr. Lee just did a group to perform the first united double hand transplantation. And I have the chance to observe the second United States double hand transplantation, and this is the patient. And in 2014, my good friend and my senior colleague, Dr. Yoren Guo, lead a group in Kaohsiung Cheng-Hung Memorial Hospital to perform the first hand transplantation in Taiwan. It's the unilateral hand transplantation. And I also have the chance to visit Dr. Subu Iyer last year, then examine the first hand transplantation recipient personally. You can see he can actually use the smartphone very well. And I also do the visiting to Daegu to visit Dr. Shen Yongwoo's group, who performed the first hand transplantation in Korea. More than 3 years ago, in 2017, our group performed the first double forearm transplantation in Taiwan. And this is a moment of left forearm reperfusion from the pale to pink. And after that, we also do the fluorescence angiography to check if there are any poor perfused area, then we can excise the skin pedal. And this recipient is a quadruple amputee. And the cause of defect is a typical infection with septic shock. Then you can see the patient have the bionic hand with him, but the left hand did not have one, because although it's so fancy to have the bionic hand, but the maintenance is another problem. So this is the patient before transplantation. So you can see the patient have the bilateral bionic hand. He can, after training, he can do it very well, but before well trained, you can see still have a period of struggle to use the bionic hand. So we do a CTA to check the vascular status and also check the bone. So we can measure the donor bone length. And we transplant all the muscle part from the donor. Then also hook up the bone with the extensor and the flexor for the bone-to-bone fixation. So after that, we use a compression plate to fix the flexor and extensor at the epicondyle. And the panel-reactive antibody before transplantation is less than 30%. And there is negative cross match for this patient. And this patient only have the one HLA match. This is a study from Dr. NDD. The majority of the HLA match from his very early study, the majority actually is a zero match, zero HLA match. 2 months after transplantation, this patient encountered the first rejection episode. So from the pathology study, we can find this is some perivascular infiltration, and also have the epidermal astrocytosis and spongiosis. So this is a grade 2 to grade 3 rejection. So at that time, we use methylprednisolone pulse therapy for 3 days. After 3 days, we find the rash subside. And this patient until now have more than 3 years and 4 months And the rejection episode only happened in the first year after transplantation. So this is the tacrolimus level. After 1 year, we usually keep the tacrolimus level around 5. And the creatine level actually is quite well, although always below 1. The WBC level still also under control. As I introduced previously, we also use ultrasound biomicroscopy to detect the intima of the transplanted vessel. So until now, the vessel actually did not show the intima hyperplasia. And this is the rehabilitation protocol for the bilateral forearm transplantation. Because this patient actually is an assistant professor in the university. After 6 months, he returned to the work. But after transplantation, he had the 5 days per week rehabilitation. In the first 2 weeks, we need to train the patient leave the bed. And because this patient is a quadruple amputee, we not only train the bilateral upper extremity, but also need to train the lower extremity strength. But after that, we do the rehabilitation. We use robotic rehabilitation to avoid the contracture and atrophy in the intrinsic muscle. And it's quite interesting because at this time, the patient still cannot feel any muscle tone and also the sensory. So, but he can, through his eye, to look at the screen to fix the finger just by this robotic rehabilitation. So this is a rehabilitation protocol we do for this patient. And at the 9 months, he sent me this video chip, have the Vitrican in his hand. And this post 18 months, he can extend the finger, but a little bit curved, but the joint is quite supple. And 9 months, he also showed me the video tape. He came back to the school and used the pen to write the whiteboard. And recently we find he still have the improvement in the intrinsic muscle function. And we also do the functional MRI for this patient. And you can see the motor. The motor have the somatosensor, sorry, motor cortex activity. And the right side also have the activation. And also the somatosensory cortex also have the activation. And also the other side also have the activation. So we review article, this is the one of the only 13 recipients have the bilateral hand transplantation in the quadruple amputee. What is the benefit for this patient? Because as not only can have the bilateral hand, but because the balance is quite different when we use the bilateral bionic hand and compared to the real hand. The gravity, because the weight of the bionic hand actually majority in the wrist and the hand. So after have this patient have the hand transplantation, he mentioned to us he have the improved gait, and we also have the data from the gait and analysis. 1 year later, after bilateral hand transplantation, we have the first arm transplantation in Taiwan. This patient is a unilateral elbow disarticulation patient. So we do the arm transplantation for this patient. And this patient have the several episodes of the skin rejection, but we still use the pulse therapy for the skin rash. Initially, we can effectively to treat the rash, but this patient have the mild humor rejection, but recently we even need to use rituximab and also the IVIG to treat this patient. But this patient now is still doing very well. And this is the tacrolimus level of this patient. And the creatine level is still okay because this patient actually have the diabetes before the transplantation. And the white count is okay. And this patient is the owner of the small company, so he came back to his work 4 months after transplantation. And we also do the UBM for this patient, and we can find in the later stage, the intima become a little bit sickness. So we, based on this study, we increase the immunosuppression drug. And this is the healthy side. The intima is quite similar to the pre-op study. And this is post-op 27 months. The patient can drive the car by himself and also doing quite well. So how about the waiting list in Cheng-Hung? Now we have the 2 patients in the waiting list. The first one is a burn injury case, and the second one is a crash one. But this one also have the bilateral bionic hand use, but he's still not satisfied with the function. But recently, this patient have the varicose vein bleeding and need to have the liver transplantation first. So I hope this patient can receive the liver transplantation. Then after that, receive the bilateral hand transplantation for him. So at Cheng-Hung, currently we have the hand and upper extremity transplantation program, and we still need the IRB approved from the government for the face transplantation. And recently we also want to launch the uterus transplantation. And for some unique case, we may do the abdominal transplantation for the suitable solid organ transplantation recipient. But for the low extremity transplantation, initially we may see it may be one alternative for this kind of patient, but due to the advance of the processes and actually the previous case done by Kavada's group, the patient finally actually developed malignancy, then reamputation, the bilateral extremity. So currently we did not want to do the low extremity allotransplantation. So today I just mentioned actually our study, and not only the bench study, but also the clinical VCS study, but it's all the teamwork. Without the team support, we cannot have this kind of successful hand transplantation case. But I think this is the final slide. And the right side is Thomas Staro, Dr. Thomas Staro. You may know him. He is the father of liver transplantation. This is the John Murray. And in his biography, The Power of People, he mentioned the history of the medicine is that what was inconceivable yesterday and very achievable today often become routine tomorrow. I think this is maybe we can have the course mark for my today's presentation, because for me, the first hand transplantation, successful hand transplantation in the world happened in the 1998, and I find the report in the Lancet 1999. This at that year, I am only the first year resident in the surgery, but at that time, I don't think we can do the hand transplantation at Cheng-Hung, but now we have the 2 hand transplantation. So with the team work and our actually hard work, we can make things better and can do a good things for our patient. Thank you very much.
Great, Luke. Thank you so much. That was a fascinating tour of your experiences and a brilliant overview of where we've come from for extremity reconstruction and coming all the way to vascularized composite allotransplantation now. Luke, I wanted to start off with a couple of questions before I bring in questions from the audience. First of all, you know, there aren't many places in the world where you can do or see vascularized composite allotransplantation. For members of the audience who are plastic surgery trainees who have ambitions to be part of a program like that, do you have any advice for them?
Yeah, I think for me, if you need to do the clinical VCA program, I think the funding is quite important. Actually, I am very lucky have all my mentors support. And as you know, Cheng-Hung Memorial Hospital is the largest hospital in Taiwan. It have lots of research grant. So if you need to do the clinical project, you need to have the funding. And the other thing is that I think the cooperation is also very important, because you cannot have the one man heroic attempt in this kind of vascular composite allotransplantation. You will deal with lots of setback and also have lots of trouble things happen. Even I have the whole group support me. Sometimes I still feel depressed. Actually, when I care the patient, sometimes the patient have the abnormal data or even have the skin rash. I will ask me lots of questions. So you need to have the funding, you need to have the team support, you need to have the cooperation, and also you need to have the very good mentor can want to support you. I think it's quite important for you want to establish a good VCA program. And regarding the basic research in VCA, it's not so difficult. If you want to do this, you need to know what is unique for your part. Because lots of study in VCA study, you will find actually in this society, lots of experts have already performed a very good study in solid organ transplantation. So that's a reason I only focus on the skin part, vascular bone marrow transplantation, and focus on the nerve regeneration. I did not want to touch too much and dig too deep in the immunology research. That's what I want to suggest. Thank you.
Thank you. So that brings me nicely to my next question for you, which is, you know, before you did your first VCA, you'd already spent many years doing your basic research, preparing the team, getting people together. It was really a great combination of innovation, knowledge, persistence, lots of faith. But when you finally got to do that first PCA and you showed that fantastic video of the hand pinking up. Can you just share with us the kind of emotional journey through the first couple of months?
Actually, I still remember after first bilateral hand transplantation, I stayed in the hospital for a month, just as a resident. I take care of the every lab data draw from the patient, and because after transplantation, the patient have actually the episode, standstill episode. So maybe allergic to a specific drug, but we still don't know. So we do the CPCR for this patient. But after that, I worry about his consciousness, but he recovered totally. But after that, I stay in the hospital for the whole month. Then after 1 month, I finally go out with my wife. They enjoy a special dinner. I would like to emphasize to all the audience, this is not a heroic attempt. This is a teamwork. You need to someone always back up you. Otherwise, you will feel sometimes you will feel very sad.
Great, thank you, Luke. So we have a question from Tariq Amari, who's one of our trainees here. And he says, with the risks associated with immunosuppression and the continued advances in bionic prosthesis, what's your opinion on the future of hand transplantation? Yeah,
it's a very good question and very interesting. Even to me, I still want to know the answer. But in my side, although you know I am the VCA guy, but I am not only go for the VCA. Only for the very specific case, I will select as a candidate for the hand transplantation. But in the other part, for the unilateral below elbow amputee, I will go for the bionic hand, because the bionic hand is quite now it is feasible for this kind of patient to have the normal daily activity. But the maintenance fee is another issue. So you can see, especially in Taiwan, it's quite hard and humidity. And the sensor chip always have the malfunction and need to send back to UK to have the maintenance. So you can see, although this patient have the bilateral bionic hand, they come to my clinic, they usually did not have the pair together. They only have the one. So I think the maintenance fee is actually is a lots of burden for this kind of patient. The other thing is, I also focus on the tucking muscle renovation for the proximal amputee, because the tucking muscle renovation and also plus the advanced prosthesis, I think is a way to go for the next generation of the patient. But in current generation of the patient, I still think the VCA is the best choice in our generation. That's what I think.
Okay, great. We've got a question from Sam Gujral, who used to work in the department I work in now, but he's now in Bristol and he's a hand fellow there. And he says, hi, thank you. So incredible to have Professor Lin's time. How are the patients funded? Do they get lifelong support for immunomodulators and potential complications such as acute rejection and also the consequences of immunosuppression? So renal disease, hypertension, diabetes, tumors.
Yeah, as you may know that in Taiwan, we now hand transplantation still is, the government still categorized this as an experimental surgery. So the hospital or the research group need to do this free for the patient and need to take care of the patient for the lifelong, not only for the complication, but also for the immunosuppression drug. So in our hospital, we each year, the hospital actually sponsor lots of money for these 2 patients. And we also want to have another 3 patients. Then the government may be this as a regular operation. And we are covered by the national health care system. But before that, the hospital need to pay the immunosuppression drug and also deal with all the complications and also arrange the rehabilitation free for these 2 patients. And the same scenario happened to Dr. Guo's patient. Dr. Guo also performed the 3 hand transplantation in Kaohsiung. And also the 3 patients also covered by his hospital, not paid by the patient. Yeah. But after, if we can finish 5 patients, just like the intestine transplantation in Taiwan, after 5 successful intestine transplantation, the Taiwanese government finally list this as a regular operation and can be covered by the national health care system.
Great. There's a question here about your cuff technique. So thanks for sharing that.
Yeah.
The question is the cuff not prothrombogenic? And does it only work in mice because they are less susceptible to thrombosis?
I see it's a question, a good question. Actually I checked the patent, Google patent. There is have already someone list the patent, but no one used it in the clinical application. I see if we need to use it in the clinical application, we may need to actually produce because now I use the polyimide cuff is a non-absorbable material. But in the human or in the clinical application, we may try to use absorbable material. But absorbable material, to my knowledge, is still quite thick. Just as I mentioned in Dr. Pear's method, it will be very thick and cause the turbulence. And because I think that the turbulence is the thrombogenic factor for this cuff technique. And I don't see, because we pour through the vessel through the cuff, then it actually the blood actually never contact to the cuff. So the cuff only can have the thrombus because of the turbulence. It will not caused by, but it will not caused by the stitch, caused by the exposed cuff. It never happened. Yeah. Okay. But I think the material should be absorbable one. Then we can try to use it in the clinical application.
Right. Okay. Great. We've got a question from Jason Wong, who you know well from Manchester.
Yeah. Yeah.
He says, "Great talk, Luke, and lovely to see you doing well. You've hardly changed in 6 years. What do you think will be your research focus over the next few years? And what's the next frontier for Cheng-Hung? Is it more clinical?"
You mean in the clinical study? Clinical VCS study?
Yeah.
Oh, yeah, I still focus on, in the rejection. Recently, we just find an interesting finding, but because before the publication, I need to keep it in secret. But I would like to mention to you. Actually, we find some interesting things in the early detection of the humoral rejection in the clinical hand transplantation. Because I mentioned in the second one, we counted several episodes of humoral rejection, and I our group find an easy method to detect and early detect the human rejection, because the antibody-mediated rejection is the cause of the coronary rejection. Before the first 3 years after transplantation, we may focus on T-cell mediated rejection, but after 3 years, T-cell actually play less important role in rejection. But you know, we still use tacrolimus as the first line immunosuppression after 3 years. So we need to, but in our second case, we find a very interesting finding. I can only mention this, but we just prepare our manuscript. But okay, the other part for the research, for me, I think the nerve regeneration study is a way to go. I think it's quite interesting. Most of people may know the tacrolimus may improve the nerve regeneration, but we need to have the very high dose in the blood, then can induce can promote the nerve regeneration. But as I mentioned, now I use the hydrogel. I carry the tacrolimus to the local transplantation site. So you may just reduce the toxic effect, but also improve not only the nerve regeneration and also suppress the rejection. So for me, the nerve regeneration part for the hand transplantation, I think is a way to go. Especially we have very good teacher, Professor David John, in our hospital, and he did 2 very good young starter, actually, and Tommy and Johnny. I would like to cooperate with them to have the further study focused on nerve regeneration.
Sounds great, and we look forward to seeing your secret manuscript come to the public light soon. Now, and that's Jason saying that will be an awesome team with you, Johnny, and Tommy. So looking forward to that. I was interested to hear about your patient who potentially will who's waiting for the liver transplantation and then the limb transplant. With somebody like that who needs a solid organ transplant as well as a VCA, will they require, do you think, more immunosuppression, or actually same as you would for one or the other?
Yeah, it is a very good question. Because in the previous study, actually, you know, Dr. Scott Evans have the one kid receive the kidney transplantation before bilateral hand transplantation.
Yeah,
he just received the same dosage of the immunosuppression as after he received kidney transplantation alone. And the other case is, I think, happened in Mayo Clinic. They performed the solid organ transplantation with scalp transplantation simultaneously. For this case, I have no idea about the dosage of immunosuppression drug, but to my knowledge, in the solid organ transplantation, you know, in solid organ transplantation, there are so many simultaneous kidney and liver transplantation, or the heart and lung transplantation. They find when you have the simultaneous transplantation, in the first year after transplantation, actually the risk of the acute rejection actually is decreased compared to the solitary solid organ transplantation. But the dosage still just need to keep similar to the solitary solid organ transplantation. I think it's will happen to the solid organ transplantation plus vascularized composite allotransplantation.
Great, thank you. And I guess there isn't much time, so I'll ask you one last question, if I may, which is, in your experience so far, what are the key lessons that you have learned that you did not expect and you can't read from a textbook or reading papers?
It's so tough. Yeah, but for me, before I have the clinical VCA, I think I just have the good study and also have the good practice in the extremity reconstruction, because I love to have the extremity reconstruction. But even like that, I still did not take actually pay much attention to the whole body, whole patient's care. But after I involved in the clinical VCA, especially we have the 2 hand transplant, I need to take care of all the details. And sometimes you will know the life actually is quite tough for me. I need to take care of the each detail, and for sometimes I think the God have his own arrangement. What I need to mention that, you know, in the first hand transplantation in our hospital, you know, the donor have the CPCR episode first in the morning. Then we have the recipient have the CPCR episode in the evening. So in one day, I encounter 2 episodes of CPCR. So sometimes in the first day, I told to my wife, maybe God just have a joke to me. But now, after more than 3 years, I see God have his own good arrangement. So for this, now it's for our reconstructive microsurgeon, even like that, even a routine free tissue transfer, sometimes I still encounter unexpected difficulty or problem. So but now I don't want, I just mentioned to my resident, we just get things done. Then I just keep our patient. Then I think after that, I just have the finger crossed with my resident. Then listen to God have which kind of answer to me. Yes, it's like that.
Well, I mean, of course, these patients, and once you've done this, they're your patients for life, aren't they? Yeah. And I remember, you know, when I was your fellow, there were many nights that after you bring the patients in, the recipients of the transplants into your clinic at the end, and you sat there with the immunologist thinking about things, and it's certainly very labor intensive and very involved. And that was very inspiring and awe-inspiring. Luke, thank you so much for your talk today and answering all these questions.
Thank you very much for your invitation. Yeah.
No, and it was a real privilege to hear you talk, and I look forward to catching up with you soon.
Me too.
Take care. Love to the family.
Thank you. Bye-bye.
Bye-bye.